I believe we're moving on into the next session of the agenda. Michael, I don't know if you wanted to say any words as we regroup, but otherwise we'll be hearing from the different breakout networking groups or breakout groups.
No, why don't we just move ahead into the debrief from the breakout groups?
Perfect. So why don't we start with the first group, which was with Oliver, Lindsay, and Courtney. You've all been made co-hosts, so if you want to unmute yourself, if there's anything you want to share, please feel free to do so.
Okay, thank you, Jennifer. So I don't know that I have anything organized enough to warrant sharing the screen at this point, but I'm going to take a stab at just briefly summarizing some of the key points from what was a really interesting and productive, wide-ranging conversation about a lot of issues that are relevant to training in cancer health economics research. So I will get started, and then Oliver and Courtney can jump in if there are any key points I missed, and anyone else who was in that session who has anything to add after I summarize, it would be really helpful to have that input as well. But to try and distill some of the themes that were that ran throughout the conversation, there was there was discussion of what's essential to training for groups working in the field of cancer health economics. And it was recognized that there are, it may be oversimplifying to say two groups. There are multiple groups, which we could think of broadly as individuals who are trained in health economics or health services research, really have the focus on the methods and that content area of health economics. And then people who start with clinical training, but have interests in health economics topics and health services research in cancer. And so there was some discussion of how, at least early on, methods training is really important to the field, and making sure that people working in the field have that core methods training, and that it may not be necessary initially for people to be focused on cancer as long as they have those core methods. But there was also a lot of discussion about, for the field, the importance of team science and collaborative approaches, and the need for interprofessional education, and the fact that the earlier that starts, the better, because people need to be able to communicate with those outside their field, be able to work collaboratively. So it was a broad conversation, and there were a lot of ways that that might be accomplished, but there was certainly recognition of the multidisciplinary nature of the field and the importance of strong methods training, but also training in multidisciplinary research. And people raised the importance of training in science communication and dissemination as part of this. We then talked a little bit about specific types of programs in this area. T32s, such as the program that Nancy Keating and Deb Schrag run at Harvard, and the kind of line between having a broad transdisciplinary program and a more focused program. There was a recognition that there aren't currently training programs with a specific focus on cancer health economics, and there are probably a small number of programs that specifically explicitly recruit people with a background in cancer health economics, but there could be a lot of different ways to bring together trainees in programs such as T32s across different institutions that have an interest in health economics. And, maybe one silver lining of this COVID era is that we've all, gotten much more familiar with online meetings and webinars. So one kind of concrete recommendation that came out was potentially convening some kind of webinar series or training series for trainees, possibly, those on T32s across different institutions, to start sort of an interest group, either, works in progress or training sessions on common themes that are going to be relevant for anyone working in this field. The Heather Gold raised the example of the implementation science webinar that's been ongoing for a long time as potentially a model to work from for that. And there was some discussion of the possibility that there might be an R25 mechanism that could support a short course. So there were some concrete items like that, but a lot of really important conversation about the need to recognize sort of pathways to bring together people from different backgrounds and different disciplines, and to foster that transdisciplinary communication and training early on and throughout different stages of people's careers. And then there was also a discussion of the importance of the field of cancer health economics to advancing health equity, sort of piggybacking on the last session before the breakouts, and recognition of the importance of really broad collaboration with social scientists across a range of fields, the importance of community-based participatory research, of partnering, with relevant stakeholders. So I think, going back to, I think what the word that keeps coming to mind is it really was a wide-ranging conversation that I think brought up a lot of important points. And it highlighted what I think we've seen throughout the conference, that because this is a multidisciplinary field, that strong methods training is really at the core, but there's an important role for making sure that people have access to and collaborations with all the relevant experts in the areas in which they're working. I think there were definitely other specific concrete points that were made, but maybe I will just pause there because I'm sure we don't have too much more time, and see if Oliver or Courtney or anyone else who's in the session has anything to add.
Thanks, Lindsay. I'm not sure I've had a chance to meet everybody. My name is Oliver Bogler. I'm at the Center for Cancer Training at the NCI. I'm not a health economist, but that was a fantastic summary. The one specific thing I would pull out as well that I heard was that the consolidation of the K07 into other K mechanisms was a concern that was raised, and it's something I'm looking at. So I just wanted to make a general invitation to the participants of this conference. If you have a point of view on that, I would be very glad to hear from you. My email is easy to find, oliver.bogler@nih.gov. But otherwise, I just wanted to thank everyone for the opportunity to listen today in this session. Thank you very much.
Hi, everyone. I'm Courtney Williams. I'm a cancer prevention postdoctoral fellow, and I was honored to help lead this discussion. And one thing that was mentioned really focused on training in communications to lay audiences. And I think this is a theme that we keep hearing over and over throughout this conference. So making sure not only that we're strong in methodology, but we can communicate those methodologies and those results to people outside of the scientific community. So understanding science journalism, our communication to policymakers is also an important training goal.
Great, thank you to the first group that presented. If there's anything that was missed, please feel free to type it in the chat. We'll be capturing that as following today's call. With that, we'll move on to Gila and James. You have also been made co-hosts, so feel free to share your video and unmute your lines.
Hi, everyone. So James and I led the discussion focused on, or the action group focused on, fostering interdisciplinary and transdisciplinary collaborations in cancer health economics. And the objectives of our conversation were to think about the barriers and facilitators to effective transdisciplinary collaboration, or collaboration across disciplines, inter or trans, and in the context of health economics research, as well as to think through what might be some public goods or ways to help address those barriers to support collaborations across disciplines, and also even maybe hopefully to provide a forum to launch collaborations among our group. So we were quite aspirational. We did start with definitions just to clarify those distinctions between multidisciplinary, interdisciplinary, and transdisciplinary. where interdisciplinary is linking disciplines into a coordinated or coherent whole, whereas transdisciplinary really integrates disciplines so that they're transcending traditional boundaries and coming up with new research questions that are not nested in a particular discipline. And we had a nifty graphic to kind of depict that, but I won't go to the effort of trying to share the slides. So James, do you want to take over in terms of how we talked about some of those barriers? And
sure, and you know, that really set the stage for really pushing the envelope in terms of truly transdisciplinary collaboration. First, we talked about we asked the group whether there are research projects for which better transdisciplinary collaboration would have helped. And there are multiple examples given, but basically studies that look not only at the clinical decision itself, but each step along the way, an economic look at you know, how decisions are made and also communicated and the information contained within each step along the way. We asked folks whether what barriers there were to truly transdisciplinary collaboration. And we heard a lot from economists about you know, clinicians not really understanding what economics research encompasses, that institutional funding centers that were housed within the medical school or the hospital seems to drop basically the economic endpoints first, or not understand the importance of the ability of the economists to do what on surface would be transdisciplinary work. And we also heard that it was difficult for economists to even keep their funding on funded grants if the grant itself was experiencing difficulties, and often the economic endpoints were the first ones dropped. We asked what were the promoters to transdisciplinary work, and we heard about informal communication and relationships between clinicians and economists. We also talked about the example of the Yale Copper Center, which is the Cancer Outcomes Public Policy and Effectiveness Research Center, which was started by Carrie Gross and Xiaomei Ma, and also led by Amy Davidoff. And as an example of a forum where essentially a lab group of people can come together and think collaboratively on a regularly scheduled and ongoing basis. Finally, we asked, what could NCI do to help foster transdisciplinary collaboration? Several things came up. There was the need for discussion after each session in workshops like this, perhaps supporting matchmaking between experts from different disciplines as a part of this workshop, not necessarily just names and phone numbers and emails, but actually listing expertise, availability, et cetera. The Office of Disease Prevention Registry of Experts was also brought up as a potential venue by which transdisciplinary collaboration could be fostered. But basically having transparent matching of skill sets in a workshop like this. And I'd love to hear from anyone else who was part of that session if we missed anything.
the only one thing I can think of is someone also, or maybe a few people, talked about training and supporting training opportunities for economists to match with in clinical settings at NCI, whatever various opportunities.
Yeah, and there was a lot of discussion how economists are often pulled, you know, that 0.1 FTE came up a lot. And so economists are pulled in multiple different directions. You know, I think in medical grants, based clinical grants, R01s, that type of funding mechanism, it was repeatedly brought up that it was important for the health economics to become a central aim and not an add-on, not a cost effectiveness add-on to an existing clinical grant. I think that's it.
Hey, thank you guys. And again, for anyone who participated in that breakout group, feel free to use the chat to chime in with anything that you thought of something important to capture, because we are recording this and we are saving your chat comments. So with that, I guess we will move on to the next breakout group that we held, which was with Michael and Deborah.
Hello. Yeah, my name is Michael Pesco. I'm an associate professor of economics at Georgia State University. So we had a very nice conversation. I, in particular, was interested in one issue that I'll talk about, and Deborah will talk about some other issues as well. So we had an opportunity to talk about the National Center for Health Statistics and opportunities for researchers to use their data in secure research data environments. There were some interesting things that we learned. Some NCHS officials, they attended. One of the changes that they are going to be making is there was previously a rule that census analysts needed to be present when researchers used the RDC environments, which made it impossible to do research, for example, on weekends or in evenings. And they're actually going to permanently relax that rule. So we're excited about that, and we think that that will significantly improve researcher access to those data sources. We also discussed that there's quite a bit of randomness in the disclosure process that makes it easier for certain projects to get output disclosed, harder for other projects to get output disclosed, really dependent on the analyst. There's some efforts to try to standardize the way that the analysts review output, but perhaps there is some flexibility that that could be permanently built into the way that NCHS discloses output. The NCHS privacy officer was in attendance, and she mentioned that historically there have been bad actors, and she articulated some issues that have come up in the past that really justify some of the NCHS's current policies. There was some discussion that some data is just too sensitive to be released except through secure mechanisms. With that said, there might also be ways to try to collect government data in particular in ways that reduce privacy concerns and make linkages more possible further down the road. And one opportunity, apparently there's some new federal government rules in the works that is trying to promote more data sharing. And so there might be an opportunity for cancer researchers to use these new federal rules in the place to work with NCHS more. And I'll turn it over to Deborah.
Thanks, Mike. So the two other types of data for health economic, potentially could be used for health economics research, were public use data sets that we've heard a lot about the last couple of days, both serum Medicare and Medicaid linkages, and also the all-payer claims data sets linked to tumor registry data. So we recapped some of the same discussions and details that we've heard in the earlier sessions. But key issues were, problems with delays, with timeliness and access, and linkages to other key sources, whether it be supply side details, multi-level factors, etc. So we were very pleased, at least I was very pleased to hear from Amy and others when she discussed the new potential linkages that were slated for the pipeline or in progress now that could deal with some of these issues, that could deal with some of these deficiencies and opportunities for better capture of a broader set of data sources. So that was great to hear. We also heard about other novel uses of the all-payer claims data sets, and that is an opportunity at the statewide level. We heard less in the public use piece. I think the focus was not on privacy issues. So I think there was less of a focus there, but more about access, completeness, maybe issues around the narrow capture, so whether it's only those over 65 or only those in Medicaid, and what we might be missing, leakages out of the source, leakages of data needed to assess the continuum of cancer care that are associated with the use of these sources. But we were very pleased to hear about the updates from NCI and others. The other topic we discussed were the opportunities, barriers, and perhaps a bit of recommendations around access and use of proprietary data sets. So two different sort of categories of proprietary data sources. One being the private sources, say from Optum, Flatirons, HCCI, and others. And, and then the other set was from healthcare system level data, whether it's examples, Healthcare Systems Research Network, the former Cancer Research Network, the Prosper Network, et cetera. So I think a cross-cutting theme with proprietary data sets has to do with cross-cutting access theme has to do with the need for collaboration. With the earlier proprietary sets, it's business use agreements and really working with the, I guess, vendors or entities that own those data, and the requirement for collaborative data use agreements and release, et cetera. And the release issue or the safety de-identification issue does get back to this is patient in the latter with healthcare system data. This does come back to patient level data and how much restrictions around that, HIPAA and others. But how work is actively being done to improve the mechanisms, processes around developing whether it's common data models and data sets for de-identification and public use release. That more emphasis needs to be put there, as we mentioned, and is what happened in the Prosper PFA, is that actually written into the PFA or RFA that this is needed as part of the research to make sure that this becomes a resource for broad that's available for broad use. And lastly, Joe Lipscomb brought up some key issues about how do we get all the folks to the table. So back to the fact that we are we live in fragmented systems, but what if you want to look at all ages across the continuum? And the public use data sources and the federal sources, including those that Mike mentioned, improving access and identification issues that's absolutely key, but also getting the other players to the table, meaning the insurance companies and the other healthcare systems. How can we collaborate more to improve broader capture and broader access to these sources? So I'll stop there.
Great, thank you both. So again, put anything in the comments if you think anything was missed. We'll be capturing that. And with that, we'll move to our last breakout group with Joe and Tina.
I can see your slides, Tina, so success.
Joe, can you hear me?
Now we can, yeah.
Okay, yeah.
Great.
I don't know where I was, yeah.
I was waiting patiently. Do you want me to just cover this slide, Tina, and you can jump in?
And please introduce yourself.
Okay, I will. Okay. So Joe Hank, I'm with Optum Labs. I'm a shameless economist by training, but since 2007 have been a cancer researcher or trying hard. So Tina, do you want me to walk through this slide? You can jump into 5.
Yep, please do. And oh, by the way, I'm Tina Shi. I'm professor of health economics at MD Anderson Cancer Center. So I've been living in this methods, health economist cancer center world for the past 10 plus years.
So our breakout session focused on design and methods for health economic studies in cancer, and we broke it up into two pieces, and I think Tasha Stout yesterday and some others alluded to this also, but the 2 pieces are data analytics, which I'm calling econometric, which is my field. So that would include randomized studies if you could do them, natural experiments, but a lot of what we do is observational data. So the SEER Medicare data is a great data source we've heard about today, and there's many others that were just covered. And the other one is decision analytic modeling. The basic example I can say is the cost effectiveness models. As it was mentioned yesterday, is they do blend together in the sense that many of the inputs from the decision analytic models do come from econometric analyses, and many of the ideas or gaps, I guess, are identified by folks doing the decision analytic modeling. So it's kind of like a set of methods that are intertwined yet different. So Tina, do you want to do the next slide or?
Yeah, so one thing to mention is when we discuss, we try to be sensitive about not everybody have to do their own analysis. Some people are consumers of the methods. So the group actually consists of both people who run their own analysis and people who work with other people on their analysis. So what we have discussed in terms of observational study, we talk about it's important to do the right causal inferences method and to be transparent about the unobserved variables and their possible direction of bias. Because a lot of time people just say, oh, I did propensity score matching, therefore I'm done. So that's not sufficient. And also we talk about the importance to discuss the selection mechanism in your model and the possible bias they might introduce. We also mentioned about skewed cost data, and there is a lot of econometrics around the right way to analyze cost data, both cross-sectionally and longitudinally. Joe especially mentioned it's very important to address uncertainty, both in observational and in modeling study. So instrument variable method, since there's really no perfect instruments, you can see that as a sensitivity analysis, and also a falsification test will be important in your analysis. We noticed that because of the availability of SEER Medicare and other public claims data for people to use, it produces an opportunity for publication, especially for trainees, but it also risks producing poor quality manuscripts. So we feel like it's important to develop criteria in peer review process to enhance both the transparency and reproducibility. Especially important is to be transparent about the billing codes you use to identify, because sometimes you could generate the wrong patient cohort by not using the right code. Then the discussion move on to modeling and economic evaluation. So there is a comment about, that not everybody can do microsimulation models. So sometimes once you have the test characteristics, you need to kind of expand the full model to capture the clinical pathway. This is a really massive task. Therefore, it would be nice if there would be readily available information on the downstream events, cost, utility for those modeling studies. And especially if those information is in public available sources on common modeling parameters such as cost, quality, and survival time by cancer site and stage. So we think this would be a good public goods to produce for research. We talk about there's a need for methods to bridge observational study and decision modeling. Those are really not mutually exclusive. And actually observational data, they could produce a mechanism to update your parameters, also to update your model as more data become available, and the new technology also become available. So your modeling finding might actually change. There's a comment about it would be helpful to use real world data from payers to try to build your decision model to provide more better quality estimates. We also discussed methods for economic evaluation alongside clinical trials. We noticed that even though there's more guidelines on modeling studies, there is not a lot of guidelines on econometrics methods in the trial-based economic evaluation. I think ISPO has 1 or 2 guidelines. We talk about the need to increase training in EPI-based method and to discuss bias possibly associated with different study design, and also for validation on underlying assumptions associated with your method of choice or your distribution of choice in terms of modeling study. So there's a bunch of recommendations. The first, of course, is funding. So we think NCI need to support more funding on methods. I think Arne van Basu yesterday mentioned something about heterogeneity in comparative effectiveness research. There's some discussion about, as a reviewer, are biostatisticians nicer or not as nice to other versus economists. I think we probably, both are not very nice reviewers to the people in the same discipline. So we think it's important to recruit the right reviewers with the right expertise because you really need people to understand the need of method. We discussed importance of developing good practice guidance on database studies. And it's also important to try to write in a way for non-technical audience so that people understand the contents. There's a need for more applied papers with tutorials or even sharing sample codes. I think people have not done this a lot, but it would be good to start sharing codes for both the billing code and also the program you use in your data. A lot of clinical fellows, they are interested in observational study because they feel like those studies are easier to publish, or at least you can publish faster. This might not be the case, but with the right topic, I think observational study do provide good opportunity for publication, but it's important for clinicians to partner with economists or with analysts who knows these methods. We discuss emerging methods such as machine learning, AI, or methods that in data science. But again, I think it's we talk about even with new method, you still need to understand what's the underlying assumption, what's the result you're generating, and also it's important to partner with clinicians and policymakers to make sure that the results are clinically relevant and policy relevant. So final point, the take-home message is harmonization. It's important to partner with the partner between methodologists and oncologists so that, to have cancer health economics researchers to use the team science approach for cancer health economic research. And we think it's also important to try to standardize the terminology, both in clinical terms and also in research method. So I think that's what I summarized from our discussion. If I missed anything, please, feel free to jump in. Okay, I'm going to stop sharing the screen.
Great, thank you so much everyone for the report back from your breakout sessions. With that, I will pass it over to Robin, who will kind of synthesize the 2 days that we've met over the last this week.